How do you turn this one on? Good afternoon. You're in the Insurance Subcommittee on Life and Health, and welcome to our meeting. We're about to begin. We're still catching up with folks getting from one meeting to the next. We have one bill under consideration today, and this is going to be a hearing only, and we will call that first bill. So, Chairman Knight, would you like to present your bill?
Thank you, Madam Chair. We are going to, this is the white bagging bill. If the Madam Chair would indulge me, I know Anna Adams is from the Hospital Association. I don't know if you would permit her to come up in case there are detailed questions, explanations that get into it. Would that be permissible? All right. Ms.
Certainly,
Adams,
you can bring her up with you.
Madam Chair and members of the committee, this is not a new subject. Many of you have heard of white bagging before. White bagging is where a patient receives a medication that has to be administered by the healthcare provider, but the plan does not allow for or makes it where the patient has to go out and get the medication from a pharmacy outside of perhaps in this case, most of the cases, a hospital, but it dictates where that drug must be picked up from or purchased from. So you've heard of that term, also white bagging, brown bagging, which is this bill also addresses down, is where a patient has to actually go physically pick up that drug and then take it back to its provider for administration. But a big issue that we've heard many times again, over and over, in regards to safety of the patient, safety in the sense that these are specialty drugs. They're very, a lot of times dangerous to administer, and quite frankly, from a perspective of it's also steering. And many of you know that, and we've been over that before. But briefly, the bill ensures that the insurers cannot deny payment for an in-network health care provider for the cost of the medication or the administration of the medication when that medication is purchased and administered in the same in-network care provider. We put in safeguards in here throughout the bill, and we can go over detail if you've got questions, but the patient can't be financially penalized when they receive their medication infusion therapy from the same in-network healthcare provider. In other words, the insurance can't force the patient to get their medication from a different pharmacy from where the medication is administered. Requires that the insurances can't require the patients to obtain provider-administered medications from a pharmacy that is selected by that health plan. And the insurers can't financially penalize patients if they do not obtain a covered provider-administered drug from a pharmacy selected by the health plan. Insurers cannot also cannot use the medical necessity criteria to deny provider-administered medications based on where the medication was purchased. And insurers cannot use third-party auditors to deny claims that the insurer itself could not be denied itself under this bill. The health plan cannot interfere with the patient's choice as to where to obtain provider-administered medication through steering or financial incentives. And the insurers cannot require patients to obtain medication from a specific pharmacy and transport this medication themselves to a provider for administration. This is the brown bagging part. And also, insurers may allow, but shall not, this is permissive, shall allow insurers, the insurers may allow, but not require patients to obtain the medications or have medications administered from a home infusion pharmacy. In other words, it's permissive. But I will remind you what's going on out there is we have companies that are owned by the insurance companies. For instance, Coram, CVS Specialty Infusion, or Optum Infusion Pharmacy, which is a subsidiary of United Health. These companies are owned and they're in-house, so and again, we've got that element of steering, okay, there. We're not saying you can't use it. If a patient wants to avail themselves of that services, it should be an option, but it should not be mandatory. And still, the bill also allows insurers are still allowed to establish higher co-payments or co-insurance amounts when the patient chooses to receive provider-administered medication from an out-of-network provider. And insurers are still allowed to deny claims based on a health insurance medical necessity criteria as long as it's not solely based on the location that the medication was obtained. The insurance commissioner is authorized to enforce the code section, including imposing fines on insurers who do not comply. And again, nothing in this bill prohibits a healthcare facility from using white bagging if that works best for the patient or provider. We're simply saying you cannot mandate this. And it applies to healthcare providers that have network contract with the plan, so that the contract dictates how much the provider will be paid for the medication, and providers will not be able to suddenly or unilaterally increase the price of these drugs. And again, we've seen this in the past. This just gets into the point where all of a sudden you sign into a contract, and maybe there's a unilateral contract amendment later on in the subsequent year, and it flips this. We're saying white bagging is not good. It's not good for our patients. It's not good safety measures. It's also steering, and we want to make sure that this practice in Georgia doesn't go forward. With that, Madam Chair, any questions?
Thank you. Let's see if there are any questions. Okay, I don't have any questions for you at this time. We do have several people that want to speak to the bill. Abigail Thompson. Yes. Please introduce yourselves and where you're from.
Okay. Good afternoon, Madam Chair, members of the subcommittee. My name is Abigail Thompson, and I serve as the Director of Government Relations and Advocacy for Shepherd Center. We're a private, nonprofit, 152-bed rehabilitation hospital based in Atlanta, and we were founded in 1975. We specialize in the treatment and research of traumatic brain and spinal cord injuries, as well as the treatment of multiple sclerosis, spine and chronic pain, and other neuromuscular conditions. We operate in ICU, and we offer various outpatient services as well as family housing for our patients that live more than 60 miles outside of Atlanta. We are proud to care for Georgians, but we also provide care to patients across the country who have experienced a catastrophic injury. Shepherd Center would like to register our strong support for House Bill 417 and appreciate Representative Knight for introducing this important piece of legislation. White bagging is a prevalent issue for Shepherd Center that disrupts patient care, delays treatment, and compromises the safety of specialty drug infusions. I'm pleased to have with me today Dr. Michael Yokelson, who serves as Shepherd Center's Chief Medical Officer. And Dr. Yokelson is going to speak more in depth about the firsthand encounters with the practice of white bagging and challenges experienced by Shepherd Center patients. So without further delay, I will hand it over to him. Thank you.
Thank you. Doctor?
Good afternoon, Madam Chair and committee members. Shepherd Center would like to thank you for allowing me to speak to you today and appreciates Representative David Knight for sponsoring House Bill 417, legislation that seeks to prohibit insurers from imposing the practice of white bagging on hospital providers that administer specialty drugs. Through Shepherd Center's Andrew C. Carlos Multiple Sclerosis Institute, we're a leading provider of infusion medications in the metro area, treating people with multiple sclerosis and related disorders. The MS Institute uses a wide range of neurologic and rehabilitative services to treat thousands of people with MS. Our in-house pharmacy and infusion clinicians experience firsthand the unintended consequences white bagging practices have on the delivery of care to our patients. In recent years, the practice of white bagging has become highly common among all types of insurers, claiming it provides greater cost efficiency. However, what is not efficient is the repeated delays in care to administer time-sensitive infusions to patients living with MS. Even minor delays in patients receiving infusions can cause them to have setbacks with progress or progression of symptoms. From a provider standpoint, white bagging poses serious risks, not only in terms of delayed treatment, but compromised safety of medications through off-site transport and exact dosage, increases hospital liability for safe handling, and inserts third-party disruption in the doctor-patient relationship. A specific example as it relates to MS drugs and many other treatments is monoclonal antibodies, which degrade rapidly in the heat and if not handled properly can lead to ineffective drug. As mentioned, the most affected participant in the process is the patient. We continually see patients drive to Shepherd for their infusion treatments, only to be told that Shepherd Center still has not received the drug from the specialty pharmacy, although the pharmacy itself was aware of the patient's scheduled appointment and had confirmed with our staff that the drug would be here in time for the appointment. Not only does this cause a huge inconvenience on the patient and the caregivers who are arranging transportation and possibly taking time off from work, but it also delays therapy, which sometimes with an every 4-week interval drug treatment can lead to lower blood levels, and depending on the length of delay, could possibly even risk an exacerbation of the patient's disease state. Additionally, the provider must now make room in a very busy schedule to get the patient back in and caught up on their therapy. Another problem related to white bagging is coordination of therapy and benefits. Patients can go often from being insured to uninsured to being on a free drug program and then back to being insured, all in the same year. Specialty pharmacies are difficult to work with in getting claims reversed and following up to enable the patient to smoothly transition from one status to another. Sometimes this involves a drug that has been sent too soon but unable to be returned, which wastes copay dollars and insurance benefits. Alternatively, brown bagging is when the drug is sent directly to the patient. In these instances, the drug might not be stored per manufacturer's recommendations, thus rendering the drug ineffective or possibly harmful. MS patients may have cognitive impairment from their disease state, which then results in them not understanding appropriately how to handle the meds, and then this further increases their own health risks. White bagging creates disruptions in the doctor-patient relationship because it eliminates the on-site preparation of the drug. Once received from the outside specialty pharmacy, doctors are unable to adjust the dosing following emergent findings from the day of laboratory results. Medication prescriptions, dosage amounts, and infusion schedules are unique to each patient's condition. White bagging eliminates the ability for doctors to modify care plans if needed on the day of transfusion. Lastly, pharmacy providers must comply with the requirements within the Drug Supply Chain Security Act, which is enforced to ensure drug product integrity when handoffs occur in the supply chain. When a provider receives an outside drug, track and trace follow-up steps are required to verify how the drugs have been handled since being manufactured. Accepting outside inventory of drugs bypasses pharmacy checkpoints and safeguards put in place to demonstrate clear chain of custody. Complex therapies require significant resources and focus when it comes to storage, dispensing, compounding, and administration. White bagging creates a shift in liability because providers are held responsible for the quality of the care provided. Even though we cannot verify the integrity of the medication obtained from external procurement, we must assume these risks for any error in preparation or administration of the drug therapy. In closing, the concerns raised illustrate unintended consequences of white bagging on patients and providers. White bagging is an issue that is not going away and continues to be an increasingly prevalent practice among insurers. We want to do what is in the best interest of our patients and doctors and urge your favorable passage of House Bill 417. This bill promotes safety, choice, and protects patients and providers from being forced to accept white bagging requirements imposed by insurers. Shepherd Center commends Representative Knight and the other committee members for addressing this issue. I'm happy to answer any questions at this time.
I don't see any questions. Thank you for your testimony.
Thank you.
Next on the list would be Melissa Rabel. If you would come and introduce yourself.
Hi, I'm Melissa Rybold. I am the VP of Public Policy for the Georgia Pharmacy Association, and I don't have much to say other than we support this legislation. Anything that gets rid of delaying a patient in getting their medication, we're in support of. So that's all. And thank you, Chairman Knight, for this legislation.
I appreciate that. Thank you. Next would be Anna Adams.
Thank you, Madam Chair, members of the committee. I am Anna Adams with the Georgia Hospital Association, and on behalf of our more than 150 hospitals across the state of Georgia, we are very much in support of this legislation and want to thank Chairman Knight for bringing it. Some of you may remember that last year we had a similar bill that addressed white bagging, although from a different way. It sort of interrupted that mid-year plan amendment. So if you already were in a contract with an insurer and in the middle of that plan they decided you can no longer do infusion services under our agreement, it would have prohibited that. This year, after working over the summer with the Office of the Commissioner of Insurance, we have determined that this is not something that can be done via regulation or rule, which was what we had hoped last year. And in fact, we do need legislation. So as Chairman Knight indicated, this bill we think is pretty flexible for the insurers while it still provides some guardrails and some safety for patients. In no way does this legislation force hospitals and insurers into a situation where they can't do white bagging. If that's what works best for that community, if that's what works best for that provider, that is absolutely still allowed under this legislation. But we do want to make sure that patients have access to medications that are safe and that they have access to medications in a place that's close to home and in a way that helps them treat their disease in the most effective way. So again, we are very grateful to Chairman Knight, and I am happy to answer any questions that you may have.
You do have a question.
Okay.
Please go right ahead.
I'm sorry, I just needed you, thank you, Madam Chair. I just needed you to say again who you were speaking for.
Yes,
I
am with the Georgia Hospital Association. We represent 150 hospitals in the state, small, rural, all the way up to large urban. We also have specialty hospitals, including behavioral health.
Do you have further questions, Representative? Thank you. I don't see any other questions. Thank you very much for your testimony.
Thank you.
Next is Heather Breeden.
Thank you, Madam Chair. My name is Heather Breeden. I represent the National Multiple Sclerosis Society. I'll be brief. We do support House Bill 417 and thank the sponsor for bringing this bill. We are pleased to work with multiple comprehensive care centers treating MS in the state of Georgia, as well as neurology offices who are partners in care. This is an issue that we have heard from patients and providers on. So thank you for this legislation.
I don't see any questions. Thank you. Michael Power.
Good afternoon, Madam Chair, members of the committee. My name is Michael Power, and I'm with the Pharmaceutical Care Management Association. We are the national trade group who represents pharmacy benefit managers, better known as PBMs. Our organization represents close to 20 of the PBMs that operate across the nation, but it is important to note that there are 70 that operate in this country. Some, as the bill sponsor noted, are fully integrated. Many are much smaller and maybe offer or focus on a small service. So they do sort of scale, or depending on their operations, their scale differs depending on what sort of products and services that they do offer. Unfortunately, we are here in opposition today to House Bill 417 because we do see this as an unnecessary mandate to plan sponsors. It's important to note that PBMs and the health plans work with the plan sponsor clients who use specialty pharmacies to deliver high-quality, accessible pharmacy services while promoting product affordability. Flexibility to continue contracting with these select pharmacies is the key to ensuring access and promoting affordability in Georgia. When a plan sponsor or health plan decides to contract with a PBM to administer their pharmacy benefit, they maintain authority over the terms and the benefit plan design, including how drugs should be obtained, by or delivered to their patients or the covered lives of their plan. So to be clear, the plan sponsor, not the PBM, makes the decision regarding cost-sharing requirements, formularies, and networks, including the use of mail delivery of drugs to a patient or provider. I think Mr. Wethington in a minute will highlight some cost impacts of dispensing drugs solely from hospitals and other providers, but I would like to take just a minute here and talk about URAC as a national accreditation organization, and to be clear, not implying that we use URAC to accredit or credential locations here in the state, simply reporting on a study that they did. They found that 99.98% of all drugs that are dispensed from specialty pharmacies are dispensed with no errors, and that 99.96% of these prescriptions are also distributed with 0 errors. So they find that there's high safety and efficiency in these programs of use of these third-party specialty pharmacies. A couple questions that I'd like to ask some of these other providers in the hospitals, where do their specialty drugs come from? How do they come into their facility? How do they manage chain of custody issues when they're receiving their drugs outside of their facility? So some of the questions that they're posing as issues and threats exist in their operations. And so we would also like to highlight real quickly before I conclude, the department this fall, I think it was in November, issued a new directive dealing with this issue. Many of my members are working through this process now, trying to implement that plan. And so I would encourage this committee to allow time for that directive to work and to see how that plays out in the market today. So with that, I'll conclude and be happy to take any questions if there are some.
I don't see any at this time. Thank you.
All right, thank you.
Next would be Jesse Wetherington.
Good afternoon, Madam Chair, members of the committee. My name is Jesse Wethington. I'm here as president of the Georgia Association of Health Plans, which is the commercial trade group which represents the state's health benefit industry. We're here because we have some concerns with House Bill 417. We've expressed those with the author, and again, it wouldn't be probably a spring if we weren't here talking about a drug issue in this building, or in this room, actually. So as Mr. Power expressed, we have some concerns about this, particularly for affordability for our members. And what this appears to be to me is there's this cat and mouse game between sort of the payer industry and the provider industry, where if we find some sort of way to squeeze the cost out of the balloon, there usually is a reaction to that. And I would suggest that House Bill 417 is a reaction to some of those attempts to control costs in this area. And so now they want you to ban it or severely restrict the practice. I understand there's a substitute to the bill. I've had the benefit of seeing it, but I believe there were a few changes made. One at the behest of the chair, so removing the private right of action, I believe, was one. That's something that we're very concerned about, but although that's been changed, we still have issues with the bill. I do want to share with you some cost information, because to us, that's really what this issue comes down to. There are pretty dramatic markups that occur when these drugs are dispensed in these settings. Typically, you hear that the hospital is the most expensive location to receive care of any kind. It's not different with the physician-administered drug or the hospital-administered drug space. So in the 2018 through 2020 time period, $7,000 is the cost for a single treatment of a drug administered in a hospital. And so they're an average of $7,000 more expensive than those purchased or dispensed to a specialty pharmacy. The similar figure for physician-administered drugs dispensed in the office is $1,400 higher on average. And I'll give you a couple of examples. So the markup for Botox, which is indicated for migraines, not just cosmetic surgery, is 78% in the hospital above the pharmacy average. It's 17% above in the physician-administered drug space. Prolia is 215% markup in the hospital, a 49% markup in the physician's office. Opdivo, 112% in the hospital, 18% in the physician's office, and the list goes on. 108% is the figure hospitals on average charge double the price for the same drug compared to a pharmacy. So that is our concern. We would like for our patients to have access to these drugs. Of course, the concern has been raised about the supply chain. I would suggest to you that we're not in the business of paying thousands of dollars for courses of drugs that are left to sit on somebody's porch in the hot sun for all afternoon and no longer be useful. So the chain of custody issues, as Mr. Power suggested, probably would be the same for both sides because there is the same chain of custody as the drug moves through the system. And again, I would suggest that because of work that we did with the chair over the interim and with the Department of Insurance, that the directives which cover the Georgia hospitals that are on the HART program, so that's the Rural Hospital Tax Credit, as well as critical access hospitals, are protected and carved out from this practice. So they will not be impacted, and what this really remains now is sort of the ability of the big systems that have market concentration or market power to continue to charge our members, 2, 3x the price for the same drug that they could get in another setting in a more affordable and appropriate, equally as appropriate method of distribution is our contention.
Does anyone have questions for the gentleman? Okay, thank you.
Thank you.
I'm going to ask if the author of the bill will come back to the podium. We just want to make sure we were working off the right LC. There was a committee sub or a substitute. Do you have a different version?
I left the committee substitute with the
Okay.
chairman's
Is that the one?
this morning.
Okay, I'll go ahead and read the LC number so we have it on record. It's LC 460576S. Is that correct?
Yes, ma'am.
Okay, because there were some changes from the original bill. We addressed things like, well, there were a couple things you want to talk about, the changes that were made.
Was one of them was the private right of private right of action that was eliminated out of concern.
Right.
I'm gonna
I
ask-
think that was the main change that was in the bill.
that was the main change that was there. I'm going to ask Mrs. Adams if she'll speak to details.
Thank you. So if you go to page 4 of the bill, there are some changes starting on line 69 in section D. And what we did in those sections is we just clarified the language. The way it was written before, the sentences were long and frankly kind of confusing, and so we simplified it and got straight to the point, but it does not change the intent of the legislation.
Thank you. We've had several others suggested that has come to the chair today, and one of them was to put some kind of guardrails on how much the markup could be on drugs. I think since this is a hearing only, that's probably something we need to talk about, to put a guardrail so there is a limit to how much markups could be. And I think a good time to do would be after the meeting to look at those. And again, this was a hearing only, and we will get with the commissioner over the change. He hasn't seen this particular bill. So are there any other questions?